Thank you for joining us today on the second virtual Sun, and we are grateful that you're a part of it. Uh, the Sun is also called as Simulation User Network, as you see, and the motto is Discover, Unite, and Learn. Today's we have two distinguished guests, but before I introduce them, I would like to also tell you the topic of this um, webinar. The topic for today's webinar is Leading the Simulation Frontier, from faculty to the leader, navigating the A to Z of simulation-based healthcare education in the CBME era. So I'll move on further to introduce our distinguished guests. I would like to introduce Dr. B.N. Mahalakshmi. She is the Vice Chancellor for Santosh University, Ghaziabad. She is one of the pioneers in standardized patients, OSCEs, humanities, gamifications, healthcare, and informatics and medical education. She is a well-known figure in the field of simulation in the country. Our next speaker is Dr. Vimal Krishnan. He is the head of the emergency department at Mahe Manipal. He is the coordinator for CREST. CREST stands for the Center for Resuscitation, Acute Care, and Simulation Training in Mahe Manipal. He is also the coordinator for Medical Simulation Center at Kastuba Medical College, Manipal. There is a lot of both of them carry a very strong weightage of the qualifications, but if I just carry on, I think we will finish 1 hour only in that. So I hand over the podium to Dr. Vimal. Please, can you take it forward? Thank you.
Thank you so much, Himanshu. Thank you, Lardell, for the opportunity. I think the one to kickstart is Ma'am. Ma'am has been a mentor figure for a lot of us, has been a teacher for a lot of simulationists across the country. I've had the good fortune to work at close quarters with Ma'am. So with all due respect, Ma'am, first word for you, and then we'll kickstart the session.
Yeah. Thank you very much, Team Lateral, Akshay, Praveen, Himanshu, for giving this opportunity. When we were actually casually discussing something that we were thinking about, there has been not many sessions on how we can actually move people from the current state that they participate in simulation-based teaching learning. They are a faculty in our simulation lab to how they can become leaders, how they can take ownership of the simulation program in their own institutes. So this is how this particular topic came about during a brainstorming session. And then me and Vimal discussed, and I think we have come up with a more like a conversational, doable, chunky version of this complex topic. So without much ado, we can proceed. And I'm very happy to share this stage with you women. It is very nice to get into this. Thank you, and thank you, Team Lateral, for the opportunity. Over to you, Vimal.
So just for everyone, why this topic specifically, Ladell, the brain behind this is already the coordinator group from Ladell. They had maybe when we were discussing, the initial thought was there's a lot of discussion for healthcare simulations in the country, which is growing at leaps and bounds, with clinical skills lab being set up in all medical colleges across the country, and at major sites, de novo sim centers are also running. How do we start from running a lab to leading a culture of safety? It's a highly challenging and ambiguous area. That's what ma'am, when she was discussing with me, was asking me to break it into smaller chunks, which are more palatable. Here we try to look into what appellate authorities or statutory bodies want from our end, and how do we set up an ecosystem which is extremely professional and sustainable for healthcare simulation and health professions education. We'll start off with one major question. Why do you require to know about leadership in healthcare simulation? Why healthcare simulation in the first place? Appellate authorities have told us we need to have clinical skills lab and sim centers. We know that there is a big gap between what is practiced and what we can achieve. We've always been trained at the bedside, and as the saying goes, medicine is always learned at the bedside. I think we've reached the new century where medicine is learned at the bedside, but before touching patients, maybe at the beds in sim centers or clinical skills lab. How do you bridge the gap between the lab and real world patient care? when you come to that, we sort of delineated a few objectives which we can touch upon. One is analyzing the return of investment through organizational alignment. We'll go to the depths of this. The second objective from our end would be to evaluate the role of psychological safety. Again, a buzzword which is always linked with consent, fictional contract, and psychological safety to start off as a triad. And finally, how do you develop strategies to overcome challenges and develop those leadership skills which are core to develop a sustainable ecosystem for healthcare simulation? This was extremely exciting for us to think through, and for me to have a conversation with someone with decades of experience like ma'am was extremely stimulating. And I was the possible inquisitive learner, was asking her more and more questions, pondering her to think and maybe crystallize some of her thought process into slides here. Again, we consider this to be an open conversation with people, and we hope to learn from you also on various different strategies in leadership skills, and some of those which have already been deployed or employed at your own sites to enhance your work in the sim center or the clinical skills lab. So we sort of, when we discuss these objectives, we sort of placed them into different categories or pillars. How do we think of the core goal? How do you achieve this core goal of the leadership? And I still remember the word that Madam had used when we were discussing. Why don't we think about three pillars or a tripod of sorts, where we can attach one to the other to make it a sustainable ecosystem? And I think in this age of Illuminati discussions hovering in the background and conspiracy theories, I think it's quite fruitful to think of a three-pronged strategy for this too. Ma'am, your thoughts before we jump into it?
Yeah, actually, why we need to think of it, all things, like one thing which simulation has taught us is to reduce the cognitive load on the part of the thing. And also that we need to, whatever is the new information, we need to put it into a framework which we already know. So when you have a framework, when you have a imagination of that, your simulation leadership rests on three legs. It rests on three pillars, what you are building that structure. So that it becomes much easier actually for people to conceptualize it and get that concept much more easily. So this is again from simulation only. We are using the learning theories from simulation to make this complex task into doable, meaningful chunks. So that is what this analogy came about.
Perfect. And ma'am, can you share an overview on how we can achieve this overarching goal, if I may ask you that? Overarching goal of
Thanks,
patient safety to
Yeah.
the action plan.
Yeah. So when you actually think about simulation leadership, like how do you take the program in your institute forward? The three things that comes to my mind, and I'll try to relate it to NMC mandated skill lab thing as we go along. The first and foremost, what everybody is overwhelmed about is operational. What is my business? How am I going to run the skill lab? So what is that skill lab going to look like? What are the mannequins we are going to have? What is the spaces we have? How are we going to run that place? So we are sometimes this becomes so mind-boggling that we are stuck in that only, and we keep seeing skill labs built. We have seen either extremes, extremely, what do I say, chaotic places where there is hardly anything, or spaces which are miles and wide with hardly any users which are going into that. So the first thing we need to think about is, what are my operations? What is the scale of my operations? What am I going to do? Right? How am I going to set it up and what am I going to do? But once you set up the skill lab, okay, we don't just, I like this particular dialogue in that movie, Mangalyam. So they'll be discussing about what they will do, how they will fix the cameras on that small satellite which can carry. So the girl will say, Mangal, we will go all the way to Mars only to take one round and come back, or we are going to do any actual work. So we need to think about having set up a skill lab. What are we going to teach there? What is the pedagogy behind it? What is the science of simulation-based education? And the third one is, see, simulation labs cannot exist in vacuum. Most of the times I find that we have overzealous people who are passionate about that lab, and only they are passionate about the lab. And the other people think that these are the people who are not into the mainstream. So you need to make the operations of the skill lab, you need to make the pedagogy of the skill lab relatable. It should have a soul of its own. We should be solving some problems for the clinicians, solving some problems for the educators present, rather than trying to compound or add to that particular problem. So most of the problems in running sim centers coming from neglecting this relational aspects. How do we fit into this, the entire ecosystem of health professions education? So these are the three legs of your tripod, or three pillars on which the entire edifice of simulation-based health professions education rests. And if I were to explore, right, let's talk about the business or the operational aspects of it. The first and foremost, no, that skill lab you have set up. If you set up only to satisfy an MC, that an MC wants 8 rooms, an MC wants this mannequins, I'm only setting it up, then it is okay. You will have it for your NMC inspection, but there will be no activity, there will be no usage, that hardly anything. So you have to have an alignment with what you're going to teach. You have to have an alignment with your organizational goal. That is the most important aspect. So having a strategic alignment. Then second thing we need to have, and some of us learn it little slowly over a period of time, that whatever resources that we are procuring for skill lab, be it hardware or software, they come with a limited half-life. There is a limited shelf life, and you need to ensure that you have maximum utilization, but you also ensure that the longevity of these things. So going in for a mannequin, which is much more sturdy and longer lasting, versus something which is cheaper, which can be done. So these are the kind of law stewardships, no, you need to take that into consideration. And what is going to be our ROA? See, if most of the skill labs which are being set up in the country in the medical colleges are not profit-based organizations. They are meant for educational purposes. So we can't really define ROA of these places, return of investment, in terms of money. So it would be in terms of the perception which we are building, the amount of educational activities we are doing, our contribution to the hospital, our contribution to the community in terms of training people. So we need to kind of define this or have an idea about these are the operational aspects. Then comes the pedagogical aspects, or the science behind teaching, right? And again, no, the first and foremost thing what we need to do is to map it to the curriculum. So the CBMA has clearly mentioned these are the skills that need to be taught. These are the skills that need to be certified. But if you think that your skill lab is going to do only those kind of skills, then it will probably very grossly be underutilized. They'll be better off with only having a mannequin in the ward, which they can teach using that. So you can identify scope for what other things can be taught in the skill lab. For example, we developed a module on snake bite, which is a little complex concept to teach, but we made it much more easier using simulation. So we need to look for opportunities in the curriculum. And so that will come only when you go through the entire curriculum and map it. And the design of your pedagogy should be grounded onto proper educational aspects. Like it has to be small group teachings, it has to be integrated into the curriculum, it has to have a proper feedback, it has to have opportunities for students to practice in real life. So if these principles are violated, it will be only like a fun exercise. Students sometimes know, many of our city students, when they go for rural postings, family adoptions, for them it is like a picnic in a village. So this will become a skill lab, will become a picnic for them to come and go and play with dolls kind of thing. And most important is we need to embrace the feedback culture. We need to embrace debrief. We need to allow them to make mistakes and learn from that mistakes in a safe manner. So that is the most important aspect of the science behind pedagogic leadership. And when we talk about the relational leadership, ensuring that the psychological safety, you have relation with your learners, ensure that they are safe to make mistakes. In fact, this is the only place where we tell them make all the mistakes you can, but make it here, not make it on the real patients. And ensuring that the students believe in what is happening in the simulation center, having that fictional contract, no, that they don't think of them as mannequins, but to think of them as real patients. And ensuring that there is variability built in, because we don't learn or we develop competence in a particular thing just by doing it once, twice, thrice. We'll develop competence when we have variations built in. So variations will also bring in vulnerability. So unless that particular part is taken care with regard to your faculty and students, this is going to be a problem. So you need to focus on your operational aspects in setting up the lab, teaching using the lab, the pedagogic aspects, and relating it to your learners and relating it to your environments. So that is what I would say that the 3 pillars of the simulation leadership. So as leader, you need to look at it.
How can you connect the clinical world, what is happening in the clinical world, to the operational aspect, the pain points, the strategic alignment point with the pain points like we had discussed, ma'am? Whatever is happening in the clinical space, can you map those in addition to whatever is happening in the curriculum for the real world? What do you say? Mimicking the real world scenario in the operational aspect. Just a very interesting thing to note specifically is that a lot of people who are looking at space prescription from the National Medical Commission or other appellate authorities have got to the space, they are chasing big toys. Now, sometimes the stewardship part, the resource stewardship part of looking into hardware and software could create their vision to be a little myopic. Is that a challenge that 800 med schools in the country would face, 800 and counting medical colleges or medical schools in the country would face? Ma'am, just a quick question on that note, because I have one each on these 3 pillars. The first one is on the operational pillar. Is there a need for that much bigger focus exclusively on the resource stewardship?
Okay. That is, again, no. This is what I think this we have already covered in NMC parlance. Getting your lab ready is the operational. Teaching or mapping to specific competency is pedagogic. And building a psychologically safe zone is the aspect. So to answer your question, no, like I have one word only to say or one phrase. See, invest on people rather than investing on plastics. See, I'll tell you one example of, we had this problem of shifting patients who are critically ill or shifting patients who have a trauma, teaching students log roll and teaching students how to apply cervical collar and all safely. So we didn't have to use really high fidelity mannequins for that. So we had to use the clothes mannequin, which Amazon sells for 4,000 rupees for that particular purpose. So if your intent is there, then you could use multiple resources. We had our own 3D model developed for cricothyroidectomy. So we used and we created using a 3D printer. So the resources are one of the ways in which we can do. See, if you insist on investing only on the highest power which is available, and say that with that only I can teach, then I can't teach with any other thing, then it shows your limited creativity as an educator and as a strategic manager. So you need to look at both. Okay, some of them give you this, so we will use it for these purposes, but we can also use hybrid simulation very, very effectively. Low-cost hybrid simulation. This is something which Lulu and Raj keep doing in many of the conferences, and they come up with really, really good innovative ideas on how we can actually convert this thing. So this is one of the challenges what you were talking about as whether we really need to go for the resources.
Correct.
Yes.
Just to add, we in the pedagogical aspect, I think we are growing at a breakneck speed. In addition to space, bar getting the resources, where human resource takes the bottom of the page, all the other things have a bigger priority. I think people are growing fast. with regards to pedagogy also, I think there's a lot of training programs, faculty development programs which are happening across the country. But I love the point that you brought out where we discuss a lot on grounded design. How do you ground your whole, like an earthing for the electrical circuit? How do you ground it to the educational theory, the base theories of medical education? How do you have that value being brought into the equation? Every medical college would have a medical education unit. Some of them would be evolved enough to become a huge medical education department. I think it's imperative for people in the medical education unit or the Department of Medical Education to have a huge stake in driving the pedagogical leadership of a sim center, and also form that sort of a, because there is a regular basic course in medical education or a basic course in medical education technology that happens at all medical colleges. Maybe there is a need for a basic course in medical simulation technology also. Maybe develop your own, like you said, ma'am. I think
Yeah.
the journey is within. Look at colleges, look at your resources, look at what you have. Think global, but act local. Think of designing, developing your own faculty development programs, cost effective, extremely, enhancing your clinical practice sort of a thing, which you can do it at your own level. I think that's one thing that strikes when you look at the pedagogy pillar. I think the relational pillar, the duty of care that we discussed, creating that environment part. I think you've got some things up your sleeve which you're going to bring in over the next few slides, which will add value to them by looking at those barriers and jumping through those barriers, of which one of the biggest barriers we were just starting to discuss. Over to you, ma'am, for that overcoming resistance from that skeptics mindset. How do you go about doing
Yeah.
that?
One of the advantages of being little older than you, Vimal, is that I have seen initially people were totally polarized. What is simulation? Nobody was interested in this. Now NMC is telling that it is needed, so we are going to do. But still it is there only, these are the people who are only dealing with dolls, dummies. So there is some amount of thing, real patients, real people, clinicians learn from real patients. See, my father might be very rich. He might get me a BMW when I kind of turned 18, but still I need to get an elbow to drive. So it is same. You might be in the highest patient footfall center. You might have lot of patients in the ward from which you can learn, but at the current scenario, nobody wants to actually be the thing. One is that our practice itself is changing and the patient's expectations are also changing. So we need to take that into consideration. But one problem that we still face is the skeptical expert. No, I know everything and what is there to be taught in surgery. So what is this going to come about it? So we need to actually look at it only as three things. Okay, I know you're teaching surgery very well, but don't you think that patient communications is still a problem or consent is still a problem for your thing? So we need to kind of suggest to them using this advocacy inquiry rather than to say that this is one shot which suits everybody kind of. And as leaders, we need to lead the system, not just teaching that skill. So we'll have to tell them it is a for the entire complex decision making algorithm that we are teaching rather than teaching only how to intubate or how to put Rayleigh tube. Yes, that is the first step to learn, but we also need to go beyond that and to teach them the protocols. So as a leader, lead the system, not just that skill. And most importantly, we need to realize that we are not going to teach all these very senior people surgery or medicine or obstetric gynecology. But what we are going to teach them is that culture of looking at it, culture of asking for feedback, culture of introducing deliberate practice before any new equipment comes, practicing it, right? Looking beyond that. So that is what we need to do. We need to kind of move it this thing. So sometimes when I see little overzealous young faculty, so this is what is the aspect which is missing. So we need to kind of overcome this resistance using the strength of the relational pillar rather than losing the strength of the resources that you have. You can't dazzle them with only your toys because you're not going to kind of win over them. And the second thing, what we need to look at it is that currently we are teaching skills, but Skill Lab is not going to stop with that, or your simulation program is not going to stop with that. You need to have a cohort of people who will actually do a diverse skills, who can do many simulation scenarios. See, I was very, very proud of the team that we had put in AVMC when we actually did the emergency life support courses and all that. There were almost 18 or 20 of us. All of us could do all the stations, all the emergency skills, and we could step in for anybody at any given point of time. If Frank is there in this meeting, I think he'll be very tickled to know this. So we need to invest on people, capacity build people. That is the most important aspect rather than this. We need to integrate it to the system. Like if we have problems with regard to our code blue in the hospital, then we need to say, yes, we will come and do in situ code blue so that we'll identify what are the areas. Or we need to identify issues in operating theater, okay, with regard to surgical safety checklist. So we need to kind of look at how we can integrate it with the existing systems, or even take that for matter, for example, in physiology. Students find it very difficult to understand the concept of lung compliance. So make that taught in simulation. That makes it much more easier to understand. So the simulation must act as a bridge so that there is a voluntary intake or takeover of this thing by the faculty rather than by forced NMC mandates. So that is what I think is the way to go forward. Again, no, it is a little broad concept, and all truly good things are truly simple. So that is what it is. Basically, it goes back to going back to your roots or fundamentals. I hope that answers your question.
True, ma'am. Just that allowing them to fail spectacularly and learn from that. This is something that I use, spectacular failures, and being comfortable with that feeling of spectacularly failing and learning from that spectacular failure is something that is a culture driven thing. And I think if we can do that, in the relational part, and in building the team that has that trust in you, that you're doing something which is extremely innovative, extremely new, and there's a good chance that you'd fail or fall flat, it is okay. We still are doing something which is extremely important and region driven, or region specific, that we're trying to do. That again is a massive addition, not the plastic but the person, and in the person, the courage to fail spectacularly, learn from that failure, and build again from scratch. I think that will lead to innovation and future proofing of the program, in addition to the toys bar, whatever that we tend to establish in our
But
system.
that failing spectacularly and learning from it will happen if you have a good pedagogy in place.
Yes.
Again, your educational principles and debrief comes in there only.
Absolutely.
Yes.
And that is why the link from MEU as an umbilical cord to connect the simulation center, the fetus, to the mother, or the whole of the uterus. I think I just trying to connect the same. One of Kolb's experiential learning cycles that we always discuss: to feel, to observe, to think, and to do. The whole cycle. I think that happens when people get together, that whole ecosystem gets together to review the functionalities in all these three pillars that you spoke of, whether it's operational, whether it's pedagogical, or whether it is relational, the soul part of it. I think it brings it all together. Can you give us a sort of a recipe where you look into all those aspects together? I'm just thinking aloud.
Okay, I can give you a cheat sheet. So what I thought was like, these are little abstract concepts. So if you have to teach abstract concepts, you have to break it into simpler concepts for people to understand. So when I was thinking, how can I put all these concepts into simple skills? Then what came to my mind was that we should use a framework which is easy. So I'm going to tell what are all the skills from A to Z of simulation leadership which you need to develop. And then I'm going to relate these skills to the three pillars that what we discussed. Okay, that is what I'm going to do. The first one is alignment. Very clear. You need to align yourself with the CBMA curriculum. You need to look for opportunities beyond what is explicitly stated, but also into the other areas which are not stated as simulation based. Like I gave an example of snake bite or anaphylaxis. which can be very well taught in the simulation lab. So align with the curriculum, align with the organizational goals. You need to align with both, right? The second thing is budgeting. B is for budgeting. Without money, nothing moves. So normally when everybody thinks about simulation lab, they think only about the investment in the initially buying mannequins. But what problems comes is when you want to continue to run the lab, what is my consumables cost? What is my daily operational cost? What is my human cost which is involved into that? So think not only in terms of money at the initial investment, how you're going to run the lab, how you are going to get the consumables, who are the people who are going to be involved in that, and what is the cost which is about it. Then we also need to think about humility, or I would say cultural humility. For us, no, we are very used to a very hierarchical hospital system. So to admit that you don't know something or to admit that you've gone wrong in something is a huge thing. No, we are not allowed to fail, be it in your NEET exam, be it in your first standard, be it in your LKG. Always we want to look at first rank and things like that. No, so learning that yes, learning can occur from failures is also something which is there. And other thing which simulation teaches you, know, so many a times that you want to run some complex scenarios, you would have planned very fantastically and all that. And how often halfway the mannequin gives up on you. So sometimes this happens, no? So you should be able to actually accept yourself that these things happen. So that requires a lot of change in mindset and cultural humility. We have talked enough about debriefing. It is actually not during simulation that they learn, but allowing them to think back, reflect, and how they are going to do things differently is what is the learning taking place. So debriefing is another skill which you need to learn. You can start with a simple plus data debrief, and then you can go into advocacy inquiry model. We need to follow ethics in simulation. Ethics have been set down by the standards, that INSAL standards are there. And also the Simulation Society has given standards for ethics in simulation. How do you construct the scenarios? How do you deal with death during the scenarios? How do you actually have ethics when you have different professionals which are running the simulation together? So these are some skills which you need to learn about. You need to learn about the fiction contract, how you will have to bring in fidelity. Fidelity not in terms of anatomical only, fidelity is in terms of physiological fidelity and more importantly, psychological fidelity. See, that's when VR comes in now. You think that you are in that room, in that emergency room, handling some stuff rather than saying that you are wearing a headset and doing it. If you're going to think like that, I'm just wearing a headset and looking into some pictures, then you're not going to learn anything from that VR exercise. So, fiction contract and how to make your learners believe in the fidelity of the scenario is important. You also need to learn how to do gap analysis. First, what is the gap in the curriculum? How am I going to bring one area? This is where our skill lab is supposed to be, and this is where we are. So, is there a gap? Why there is a gap, and how we need to bridge that? We need to do. So, gap analysis between what needs to be and where we are is an important skill. That introspection, metacognition is a very, very important skill for the simulation leader to learn. And most important, no, we have to constantly keep asking ourselves, am I developing myself as a simulationist? Am I developing my faculty and taking them along as we are going in this journey? So human resource development, not only that of your faculty, but also in terms of your technical staff, in terms of your other assistants who are working in that, your standardized patients. So there is a lot of human resource development involved in simulation. Then comes integration. Integration across departments, integrations into the curriculum, bridging the gap between theory and practice is a very important thing. So again, that comes from a good clinical background, good educational background, and good knowledge of what is the curriculum that we are going to follow. You need to have this idea of just-in-time training. There is a new ventilator which has come in. The staff nurses need to be trained, so you can do that. There is a new complex posting or difficult clinical postings which is there. So you can actually have just-in training for that also. So depends on what is going to be the need. You also need to be able to define what are your key performance indicators. So how do you know that your sim center is working well? And what kind of outcomes that are you going to project to your people? Taking care of logistics is the bread and butter of being a simulation manager, the strategic manager. So every day, how you're going to take care of the logistics. You have a small space, but you have 100 students suddenly coming in for the simulation lab training, or 4 different groups are in your sim center. So how are you going to plan the logistics, space, mannequins, human resources? So that kind of planning is important. Are you being mentored by somebody for your simulation journey? If not, look into it. And if you have taken the journey for some time, are you mentoring somebody? Are you giving back? So that is another thing that we want people to do. Networking skills, developing a network of people, getting to know people, how things are being done across the country in different places. That will also help you to grow as a simulation leader. We talked about outcomes in terms of patient safety, outcomes in terms of student education, outcomes in terms of financial. So all 3 things you need to look at, all the 3 pillars which are required. Psychological safety of learners is another important aspect as a leader that you need to ensure, and you need to monitor that whoever is teaching in your simulation lab under also are following these principles. Simulation should be a logical step for quality improvement, both in your lab so that you get accredited, but also across the systems. You need to teach kids these days a lot of resilience. Okay, we've seen people breaking down, especially during COVID, like when they see death and all, they just can't take it and all. So, simulation exercise teaches you that you need to do a lot of resilience training. So, that is another important aspect. You need to know the standards which have been set for simulation, especially INCCL standards. Teamwork is a very important thing, no? This is the secret sauce of success in simulation. You need to understand tech. You need to understand, like, it'll be very nice if you have a Simman 3G that which you can actually use for listening to heart sounds. But it will also be nice that if you can use a simpler monitor with Bluetooth device so that you can connect a Harvey with a Bluetooth device so that the whole class can hear it. So you need to have a little bit curiosity and trying to understand technology. And vulnerability is a part of clinical practice now. So none of us are going to get it right every time. So we need to say that sometimes we will fail. Sometimes we will fail spectacularly, but we need to build that resilience across. So that is something which you need to do. I've seen some students crying because mannequin died and all that. Especially this happens when there's like NRP we are teaching and the baby dies. So it becomes a problem. Workforce management goes without saying. What is that X factor which keeps you going? What is that passion? See, you can't do all these because these are all a lot of extra efforts, and unless you have that passion in you, so it is very difficult to do. The X factor in simulation leadership is the passion. You need to have a little bit youthful mindset. Like our Vimal is always 22 or 23. So he is
22
not
and a
more
half.
than that. 22
22
and a half. So he's always 22 and a half. So you need to
Been
have
there.
that mindset. Yes. So that is very important for you to acquire new skills and keep learning as you go along. And you need to be the evangelist. So this is most of the times this baby nobody wants. So you have to have that zeal to represent your center, to fight for your budgets, to get things, to get people coming into the simulation center. So a lot of zeal is required. So if you actually see this now, A to Z, you would see that I have color coded them. So what is in blue is all these skills which you require as a manager. Workforce management is in fact the skill of a manager. Whereas following educational standards is that of an educator. You need to know how you're teaching. But a lot of skills fall in that relational category, having the zeal, passion, teamwork, understanding of technology, etc., etc. So I try to make it a little bit easier. So if you're a strategic manager, what are the skills that you would need? You would need advocacy or zeal. You would need to have a budgeting process. You need to have integrate it with the existing systems in the hospitals. You need to plan logistics. You have to develop your own networks and outreach. And most importantly, work for quality improvement, manage your workforce. So these are the things which are required for the first pillar. With regard to the pedagogic pillar, you would require debriefing skills, following ethical standards in simulation, faculty development or personal development as professional development, learning to do gap analysis, building resilience, following standards and setting standards, and having a youthful mindset. And the last one, as the cultural transformer, that is the relational pillar that you want. So you're changing the culture of the organization. So you need to model humility, just-in-time teaching, mentorship, building in the safety culture, the trust that you can actually build in using your fictional construct, having a youthful mindset and understanding technical, ensuring that vulnerability is part of learning, which is acceptable, and clinical decision making, the X factor and the passion and zeal that you bring in. So you need to be a manager strategically, you need to be an expert educator, and you need to be the cultural icon for your institute. So that's how that you will break down that skill into A to Z. But instead of looking at it as huge, big baskets, if you can say that, okay, I'm going to work on one at a time, or I will take two skills at a time and then work on it, then the whole competency becomes much easier. This is like same thing how we learn to put an IV line before we learn to do a mega code.
So like those Lego
think
bricks, right, man? Just to add, those
Yeah.
smaller Lego bricks, you're just trying to build something into it,
Yes.
to tell them a story. I recently
Yes.
stumbled upon this meme where they said that if you chaos is when you have a lot of different colored Lego blocks grouped together in one basket. Order is when you order them in different colors, the orange, the blue, the greens, and so on, according to the colors, the right colors together. And when you convert it into a story, you use all those Lego blocks to create a house using all the different colors: the green colored lawn, the roof which is orange in color, brown in color, the windows which are blue in color, the house which is cream in color, and so on and so forth. You tell a story. On similar roads, you've given us all the blocks. Can you maybe put it all together for one quick look, a summary look for a leader? What would a leader mapping all these for a leader on those the tripod that we discussed in the beginning? When you put it together,
Yeah.
how does it look like? Just a quick look. I think that's what you're jumping into next.
Yeah. So I'm trying to talk. Okay, no, I'm not going into that. I'm going into that personal development plan. So when I'm trying to put it into that, the first and foremost is your simulation pedagogy should be based on your educational pedagogy, which should be based on the curriculum. So that is the one. Don't teach what nobody wants, what you are only wanting. Teach what they want to learn or what they have to learn. So that's the most important thing. Find plastics, find mannequins, find means to teach it meaningfully. So that is where you come in, and as a strategic manager, the first pillar or operations. The what you have in your lab should match what you are trying to teach. So if you are teaching something just because you have something in the lab, then it doesn't really work. And most importantly, if you want a buy-in from all the people and you don't want to be the only person who is doing it, you have to use multiple opportunities to promote how well this education can happen. You have to keep on showcasing what is going on in your sim lab. No, otherwise we are very content to sit inside the lab and not come out to that open and then say, if they want, let them come to the lab and learn. That's what is the most of the times
Perfect.
see.
Perfect.
So
you
you
be an
have to
expert.
take the message across. So if I say no, all three legs are very important, then only you will have a balanced tripod and you can take a perfect picture. Otherwise, imagine a crooked tripod, one leg is short and the other leg is extremely long. Then you will get some vague pictures only.
Then you'll be Pushpa, right?
Yeah.
So what is a quick personal development plan that you want to throw at all the people who are listening to you right now as a leader?
I can tell you the generic plan. Maybe you can go into specifics of how you are running in your institute. But if I were to talk about it, try and get some formal training. At least there are some courses. See, like most of the medical education courses cover the principles, whether it is ACME or FIMAR, and many of them cover all these principles. Or there are dedicated training programs across the country. Lateral runs one, PediStars runs one. Like there are many programs which are available. So we can think about formal training, at least initiate you, right? The baptization of simulation should occur through one of the formal training programs. That's very, very important. Then you can come and start yourself. Start small. Before you run a full simulation session, think about how you're going to teach one small skill, or how you're going to plan one ASCII station, how you're going to train one person to act as a standardized patient, right? Then you can think about actually running a complex skill training sessions. Also, no, when you're actually doing it, you're so involved, you really don't know whether how it looks like or in the pot. So you can either record the sessions, view yourself, or better still is to call some peer and then take feedback from them. So if feedback is so very important, we think that we are always on the higher end giving. So the receiving feedback is also a part of cultural humility, which we need to develop for learning anything. And most importantly, we should be able to connect with what is going on. So that is the connect with people, have a network of people who are there. So many of these discussions forums and in the simulation will actually stimulate you to think like this. See, there is one, the PediStars program. They keep talking about different mollages or different scenarios that they develop and all. So when you actually see all this, no, so you also are prompted to think on all those lines. So get initiated through a formal activity, start small, then take feedback along so that you can do deliberate practice of your teaching skills and how you can modify and develop your network. So that is how you grow as a simulation educator. So if you're talking about the operational aspects, the primary focus is we are only talking about, is the lab open, stocked, is it NMC ready? If they come for inspection, will I pass or not? But when you start thinking about pedagogy, you start thinking, am I growing? Am I also taking people along as I grow? Or my faculty members are also growing with me? But when you think of yourself as the change agent or the cultural transformer or icon in your organization, you're going to start thinking as, am I part of the community that is building, changing patient safety culture, or bringing in patient safety in the hospitals, ensuring safe care of our patients. So that is when your idea, you start with one and it becomes widens and widens like a ripple in a pond. So that is how you go into this. So start with one of the skills, but then acquire the competency. Then you become the Zen master. So
Just to go back to the previous slide, man, I'll just add a small, simple, real world change of what has happened. If you look at a lot of standardized resuscitation training programs, they use bits and pieces of simulation for teaching, which is rooted in medical education theories like patents for skills teaching in ATLS, for example, or other life support courses per se. You do a BCME, there is a chunk of medical education basic theories that they would teach you. We go into advanced courses, like you said, with PediStars or a PASH or a formal training program. I had the good opportunity to be part of the academic life in emergency medicine. There's a FACUBATOR program where there was a specific wing for healthcare simulation. There is the American Academy of Emergency Physicians who got a special wing in healthcare simulation. There is the NHET with Monash, which is doing some formal training there. Again, micro credential courses from online to hybrid. And I think the recent Ladel has also put its chunk into Simpagin and courses where they're specifically looking at faculty development and personal development programs for the same. Start small. We started with smaller chunks of SP training and how do you do OSCEs, how do you map that competency to UGs, and then go into non-technical training, from skill to multiplayer non-technical skills, more complex skills put together. Peer observation using technology, whether it is with something which is existent or developing simpler checklist-based strategies for different people to come in and review you. And more importantly, like you said, having a network where people can mentor, come see your work and give you adequate inputs to evolve. I think simulation, and healthcare simulation, the growth that is happening with these four generic components that you've told us at a medical college level or at a standalone simulation center level is always dependent on how much zeal they have to pull all these together. The crew that you have, there's a lot of discussion on crisis resource management and crew resource management. I think how do you pull your crew to go through step 1, 2, 3, and 4 to as a personal gain and also as a team gain. I think it's important to think of it as a team gain for that whole ecosystem on how do you start small and then build and connect that network to be mature enough to learn newer things and to stay humble enough to learn newer things at every point in time. Today, maybe we pick up a couple of points from our discussion in the chat groups too. So I'm not taking a lot of time to talk about the PDP here. Maybe as a last point, moving forward, what are we looking at? How are we going to proceed?
Once you develop your personal development plan, no, how do we move forward, or what is the road ahead for it? So the first thing, no, always starts with reflection. So look at your own sim center, look at your own stuff. So find out which leg of your tripod is the shortest. You might be doing okay with the business aspect of it. Maybe the education is lacking, or you might do both of these things, then the relational component may be lacking. So try and find out which leg of your tripod is shortest. Then try and ensure that you level up that particular leg. Most importantly, what I have seen, most of the sim centers currently are being managed by people from basic sciences background. Like they do excellent job because with their training in education, their ability to focus on tasks for multiple hours at a time, and the connect they have with the students and the delivery, all that is fantastic and they are very much available. But most of the times what I find the problem lies in building scenarios in a vacuum. So you have to have clinical partners coming in. You have to have people from general medicine, surgery, emergency coming in who is giving you real clinical scenarios, real clinical problems which they want so that you can teach in that. So you need to find those people. And most importantly, you need to ensure that your sim performance remains in the lab only. It doesn't go out. We don't discuss this in the cafeteria. So that is another important part of the initial pre-briefing which we do when we do in all the simulations. So that is what I think we should look for. To try and audit your own self, try to get partners across departments who will help you to run a more robust program and ensure that you keep up with the standards of simulation learning. So I wish everyone huge success in whatever they are learning. Many things that we've learned with a lot of hit and misses, like the same way we learn from simulation. But we've also been fortunate because there are a lot of people who have helped us. Personally, I have benefited from my association with Dr. Dinkar Pai for a very, very long time. I've learned my ASCII medical education from Professor K.R. Sethuraman. And I've also learned a lot from my team with whom I have worked, Raj, Dr. Frank, and others who were working with me, and the current team which I'm trying to put together in Santosh. So I'm very happy with the human or the connections which we have had. So that is the most important aspect. So you need to have your own network because you will always find something to learn from everybody. So being a leader is being responsible or taking up more responsibility. It is not shunning work. That is what I feel as the bottom line. And if you think about learning one skill at a time, one day at a time, then it becomes much easier in the long run. And it is a doable task. So chunking and micro chunking is the secret sauce of success.
Right, ma'am. What must give light must also endure burning. I think there's a lot of work that a leader, there's a lot of responsibility that a leader would have because most of the centers would have people who are not de novo simulationists or have only one job. There is a there is a moonlighting or let's say a day shift or a day job, evening job sort of a thing where people might be working in a specific department and then would have simulation as the other hat that they wear. Imperative to form good teams, imperative to ensure that you empower people who are with you and find the next generation of people. Leadership is also finding the next gen people to come, stay with you, mentor them, and keep them close to you. And definitely empower them, liberate them, and give them the autonomy to do things. That is true leadership. One good thing that we realized is we should break silos. We have this thought process that doctors need to learn simulation with doctors. We are thinking of medical students. We are thinking of PG, PY2, PY3 classes. We are thinking of PG classes and PG classes in one discipline versus no discipline. Break that silos. It's probably your biggest achievement if you are able to break silos, at least in your own university or teaching hospital, where you can get nurses, doctors, technical staff, allied health professionals to come together and do workshop. I've had the good opportunity to learn from some of the masters in the game. Even ma'am had being our adjunct faculty, we requested her to come here and do a lot of interprofessional workshops and simulation programs. It's initially hard to break, but it'll snowball into more and more people taking up leadership roles and taking up facilitator roles in coordinating, bar running the workshop. And I think one good thing about leadership is you telescope from one edge to the other, get more people into the fray, convert more people into empower and convert more people into taking up that role and running those interprofessional simulations with a culture which is non-hierarchical, non-triangular, although we said about three different limbs, making it as spherical as possible so that sometimes you would have different people from different professions coming in and leading your same sessions too. And that's a good start. And I think when you look at resuscitation programs, that's one good thing that you learn. People who are clinicians are also coming in, non-doctors are also coming in, people who are allied health professionals are also coming in as course directors and leading programs. And that's something that we need to learn from, specifically in the Indian context, where colonialism is deeply rooted into our DNA. And we need to break free from those shackles. I think somewhere we're still stuck in the colonial era. Now, I think IP simulation is not very hard to achieve. You just need to ensure that you take lead to break shackles. Just one comment that I saw about whether IP sim-based education is something new. I think it's not new at all. It's something that you can easily cascade at your center. Ma'am.
Actually, I have one point to add, Vimal. When we talk about integration, no, we are talking about integration between subjects. No, that integration has to happen in our
mindset
that we are all going to get from all the other people. No, so once we are convinced, then we'll always find few people who are thinking like us to convince, and then that's how that is going to snowball. So the integration has to happen in our mind. Like technician cannot do this or a nurse cannot do this, and that part needs to be done, and then it becomes much easier to integrate it into the curriculum. And I find even there is a lot of gap between the theory which is being taught and practical which are being done. So if we can think in terms of first the ultimate outcomes, what we are trying to achieve, then it becomes much easier.
I think if people can go back as leaders, bar coordinators, bar domain leads in healthcare simulation with one sentence, I would say, forget the plastic part. Everybody's chasing the plastic, the toys, the paraphernalia. Look at the people, invest in the people, and can get people from all disciplines and all genders involved. Ensure that you have the right people. You groom the right team. You create that autonomy and camaraderie among team members. I think that's a secret sauce. Like ma'am said, teamwork is a secret sauce. It's very cliche, but for sim more than anything else, grooming the right team is the easiest solution to running an excellent simulation center. And if you travel across, one thing I've noted, because this is the secret at most of those centers which are running really well, they would have one good team leader that people depend on, but all of them are leaders of their own in their own domains, bar ways in which they teach, bar do the logistics work, and it's important for us to again put the spotlight on the team and not that particular clinician, not that particular doctor who is leading a sim center, and that is, I think, a take-home message for people on leadership in healthcare simulation. Don't run a lab. Maybe lead a culture of patient safety, lead a culture of enhancing clinical practice, lead a culture of ensuring that this teaching would be changing work on the floor every single day, every single shift, and you're going to save more lives. I'll end with what my teacher always tells me: Vimal, you want to save a life, go at the bedside every day. You'll save lives at the bedside. But if you want to save a generation, teach. And probably the easiest way is to simulate. Ma'am, over to you. Just taking those questions one after the other. I'm just checking more questions on the way.
Okay. Is there a question to me, Vimal?
Multi questions are there, ma'am. I'll take ones. What is the biggest challenge students face when moving from sim lab to actual patient care? Biggest challenge.
See, initially, if they take the simulation sessions as playful games kind of activities, then it becomes a little difficult. The realism to kick in. That mannequin doesn't cry when you actually counter a vein, whereas patient will counter. So that part, no. So whether that is where that fictional contract and fidelity comes in. So we want to ensure that that part is done. That is the biggest challenge that they face. They have practiced many times in the mannequin, but when it actually comes to the patient, they will find struggle little bit to do. But it is like again, driving with a elbowed car with the whole thing controlled by the instructor, then driving on your own. That you will soon settle down.
Ensure realism, map it to the competencies, ensure real world practice. And the vacuum that ma'am said, maybe connect with the clinical colleagues to ensure that thing is happening. I think a lot of curriculum are looking at vertical and horizontal integration. Yeah. Ensure that you look into real world scenarios and what is your real world question that those kids will practice and not the ones which are seen in probably virtual reality. Currently, what is happening is the northern hemisphere or the international medicine thing, which probably might not be applicable for a person who are, let's say in Karnataka, we're looking at Kaisanur forest disease, and I'm talking about something which is extremely different from the geographic profile that they get. So maybe be mindful of acting local, thinking local also.
There is one huge comment. Alternative. I didn't have time to read it, but Sun is a wonderful webinar, something. Okay.
Questions. I'm trying to see what questions. As physiologists, it becomes very difficult for us to get a volunteer student when you're going to teach different system examination, clinical physiology lab. What are the alternatives in simulation?
A lot of mannequins which are there, which provide a lot of physiological parameters, fidelity, which is there. So Lateral has a good number of mannequins. Then CAE also has. So you can go into the SimLab and see what is available. But for currently, I don't think any student will take off his shirt to be examined by his colleagues. So those days are long gone. So you need to explore the systems and see what is possible than sticking on to age-old practices of teaching.
Some traditional, maybe think of hybrid simulators with wearables. For example, wearable simulation and delivery, wearable simulation and examination of the breast, wearable simulation and doing as simple things like an intramuscular injection or a sub-Q injection. So think of how you can make it more inquisitive, or pique that curiosity in the student. How to make failure a part of simulation workshop and how to address, how to avoid it, like CPR or cadaveric surgical workshop. I think what madam's question was how to make failure a part of. I think once you run simulation scenarios and you don't try to control the flow, probably we will encounter spectacular failures, which we can possibly provoke them to think, reflect, and correct. I think the root thing would be doing a fantastic debrief rather than providing immediate feedback, or the urge for the master or the teacher to step in and do that small group teaching in a simulation scenario is extremely high in India. We try to teach rather than facilitate. I think one thing, Anita ma'am, would be that.
There was only one thing which I want to say. If death is the outcome that you want, it is one of your learning outcomes. Like if you make this wrong and then it goes, the mannequin can die, then this is one of the expected outcomes, then you should allow the scenario to go. But if death is not one of your learning outcomes in that particular clinical scenario, no, then deliberately killing mannequins is not an acceptable standard. So that is something which you need to think about, because if let us take that untreated anaphylaxis or anaphylaxis which is not going well, so possibility of death is a very strong possibility, and that is one of the learning outcomes, that how in ineffective management or untimely management can lead to death. But if you are running a simulation scenario, let's say about I don't know, maybe a low risk simulation scenario for something else, no, and allowing that mannequin to die because they have taken wrong steps, no, that is where we have all these confederates which are coming in, and then they can tell how to go about doing it or correcting. And then that facilitator has the thing to go step in and say that the scenario stops at this point of time because they've made it. So better for them to prepare again and come back and run that scenario. Because that is one ethical aspect which we have learned in running the scenarios. Don't kill the mannequin unnecessarily unless it is part of the learning outcome.
True. We've done a systematic review on that too for people to read up on whether you should kill a mannequin at the end of sim. One final question. In the curriculum, almost all MBBS clinical duties or skill lab postings are from 9 a.m. to 12 p.m. What is your suggestion in changing the time while preparing the curriculum from 10 to 1 and 2 to 4 in the skill lab? Now, I think most centers are doing that, sir. We run a center where we've got 250 UG students, and we do form a calendar where we have postings in the evening also, in the afternoon sessions also. Depends on the availability and the utilization of the lab. You can plan that calendar, sir. We do it in the afternoons. There are multiple departments of ours: OBG, pediatrics, surgical disciplines. So we've got different days, and we put in a calendar that way through the medical education department.
Actually, I can share one very nice practice which we used to do. See, we had this very low cost task trainers from Lateral called as modular skill trainers. These are very lightweight task trainers. These are just basic body parts which come with a stand, but you can practice a lot of skills. So what we did was we put the checklist for learning these skills into our sim capture program. And these mannequins were available to the students. So when they walk in for their clinical postings, no, some of them can actually even sign off and take these things back home to the hostel for them to practice and come. So if you have resources and if you are little resourceful and how to use these resources, then you can actually use your simulation lab as the new library for learning.
And that is a future.
And we also can actually, we made it open for the students to come in the afternoon or after hours if they can sign up. Like we usually used to stay around 5, 6. So if they sign up, they can come in the afternoon and practice specific skills. Like they will pre-book, like how they will order in the restaurant. No, I want to come and learn catheterization. So they can come and actually pre-book the station and use it. So it depends on how creative your scheduling can be.
One final question, I think Vijay has asked a question: how to go about multi-patient simulations without overwhelming the facilitators or the learners? Multi-patient. Vijay, just to clarify, do you mean that there are multiple patients in the simulation? Is it the scenario design that is at fault? Or are you claiming it is a disaster scenario and you've got multiple patients and the learners have got to simulate with multiple patients? Vijay, if you can hear us. Dr. Vijay, you can type in this. I think one.
I don't know whether he says something about disaster drill or. Possible. I'm not sure what he means.
Possible. If it's disaster drill, I think engaging with better quality metrics. I think in the age of AI and VR, there are VR simulation scenarios where they do not look into that specific psychomotor skill, but look at their understanding of what you're going to do with particular cases and look at metrics of how much time-bound metrics of how many cases you saw in that particular scenario? What all did you do in that particular scenario? Did the patient go through a normal algorithm pathway or the failed algorithm pathway? There are multiple matrices which are coming in. I think usually
technical.
simulation designs do not give that cognitive overload of multi scenarios together. They focus on multi team members managing a scenario rather than one patient walking into a room and trying to manage a lot of scenarios. It could be a little chaotic because
Okay.
simulation scenarios run for 8 to 10 minutes, maybe. If you do
There
it
is
more,
a
go ahead.
explanation, Vimal. It says that multiple patients in ED, not disaster mass drills.
Okay.
So this we can give an example from how our OG department used to run simulation drills. So what they did do was they will have multiple patients. There will be an eclampsia. There will be somebody who is bleeding on the boat. There's somebody who's trying to deliver beach delivery. So they would do this prioritization exercises. Like you have a limited team of four residents and one consultant who is there, or there is one nurse and one intern and one consultant who is there. So how are you going to do that? So that kind of scenarios they do as prioritization challenge. The challenge there would be which patient takes the priority and how would you stabilize, rather than running the full scenario in each of those patients. So the learning objectives of the session will be different from what they had done. I'm not sure if
Correct. That is
in
what.
emergency
So
what he does.
even specific learning objectives in multi-casualty incident, not a mass casualty incident, but a multiple casualty incident coming into the AD. What do? Your SL or specific learning objective would be to come review these and then prioritize these patients rather than go in depth for the individual resuscitation. You've got one code blue coming in. You're going into that code blue deep resuscitation, or you're going to look at multi patients coming into the department and going to prioritize their treatment plan based on their criticality or equity.
Yes. So most of this discussion, what we try to focus on is the soft skills development for simulation. But there are a few questions about the technical aspects of simulation also. That's what I'm trying to see.
Praveen, anything that you see which we've not addressed at one look?
Well said, Vimal. There is one, I don't know for when it came, but it is here. And Frank has told something that we have learned. What is the biggest challenge students face when moving from that? There are no questions. Most of it is a comments only. I think.
There was an early question, I'm sorry to disturb, which said, how do you structure the mandatory 1.5 month skill lab posting before the clinical posting?
Okay. So we can actually kind of try and do it in different ways. We can actually build in the simulation postings for each department. So multiple ways. No, you can have fixed days, like every Monday, medicine second year will come. Or we can do it like in this posting of 4 weeks. So the last full week we will be doing simulation lab postings. So each institute can develop what is best suitable according to their needs. So the best thing about it is you need to be a little flexible when you're trying to do, but you need to put it well in advance so that everybody gets to do that thing. You can't change these rotations once they start happening, then it will result in a lot of chaos. So pre-planning and being flexible is the answer.
Thank you, Dr. Mahalakshmi. Dr. Anurag, I hope that has answered your question. I know I'm very cognizant that we are running late. Maybe I'll just wind up in a minute or so. If there's any final question, please put it in. And if we don't have time to answer it right away, Dr. Vimal and Dr. Mahalakshmi will get back to you through us. So please feel free to contact Akshay later as well if there's something that you want to clarify. A big thank you. I think we were talking so much about leadership and mentorship, and I really want to place on record that Dr. Mahalakshmi and Dr. Vimal, you've been fantastic mentors. Thank you for taking the effort and the time. It was such a free-flowing, natural conversation, and I really enjoyed it. I think a lot of people here will agree that we had 75 plus participants at earlier. And I think all of us have at least 1 or 2 points that we can try and implement. I love the way that you put it as 3 pillars and an actual personal development plan. I'm going to try and find the X factor. So A to Z, beautifully put. Thank you. Each of us has to find our own X factor. So thank you again. Just for all the participants as well as our panelists, the sun will come again. We do have almost monthly similar webinars. So please join us next time, and we look forward to learning together. So thank you again, Dr. Mahalakshmi and Dr. Vimal. We had a wonderful
Thank you so much for coming in, taking time out of your busy schedule to come have this conversation with me and trying to be a sport, even though it's me at the other end.
Thank you, Praveen. Thanks to Team Lateral and also to all the participants who had taken on a Friday evening that they had better things to do, but they are sitting and listening to discussions on leadership. And a big thank you to Vimal, my co-host, for making this session so very interactive and putting it across the questions in such a way, and sharing the Manipal experience and the ED experience, which kind of enriched what are the abstract talks being discussed. Thank you, everyone. Thanks, Vimal.
Thank you, ma'am.
Team
Thank
Lateral.
you.
Thank you, ma'am. Thank you, sir.
Thank
Thank
you,
you,
Akshay.
everyone.
Thank you,
Good night.
Himanshu. Thank you.
Bye.
Thank you, Arvind.